for medicine it's not yet a common way of calculating cost. Cost is, so this is my understanding, and I think your next interview, Paul, will be better at this, is based on number of beds and on the need of the local population. So, for instance, the neonatal death rates in an area near to here are some of the highest in the country. So there will be special funding to try and improve those rates. And if you look at the deprived, and Birmingham has many very poor areas, then those areas have much higher rates of admission and have higher rates of diseases related to poverty than areas such as where we're sitting now. So there are very marked contrasts across an urban area. We, at the moment, also have difficulties in ensuring that all ethnic groups get access to healthcare. So Birmingham has now, in its schools already, over 50% of children are from non-English backgrounds, with Southeast Asia being a very important part of the population. And if you look at the big population groups in Birmingham, then Indian, Bangladesh, Pakistani, and then Afro-Caribbean groups are the biggest, but there is a very large Chinese community. There is a Korean community whose size I don't know, and there are also non-English speaking European communities in the city, and we know clearly that those who don't speak English get worse access to health and social care than those who do. And at the moment I have a special project running looking at that as a problem. So the poor will get basic health care in exactly the same way as the rich, but as soon as you get to conditions for which they're not emergencies, then I think it's very clear that the rich get a better service, because they can also access private care if there are long waiting lists. And also I think we're showing what some other countries are showing, is that the divide between the wealthy and the poor is getting wider, not smaller. So although everybody gets a basic level of benefits, those benefits can be below what we're politically calling a living wage. So real poverty exists even in rich cities like Birmingham. And I was in fact told a couple of days ago that the difference in life expectancy between Sutton Coldfield in North Birmingham and this sort of area is 12 years, which is an enormous difference in life expectancy in one city. But Sutton Coldfield is very rich, and lots of this area are not very rich. So clearly significant problems we're not tackling in terms of the effects of poverty, isolation. We have a short distance from here the largest single mother community in the city, and city policy used to be to put everybody who was deprived into social housing in one area. So of course things then got a lot worse in those areas because there was less support. The family doctor system, I think, is at its best is superb. As I said, everybody who has an address is on a doctor's list. I used to run a night shelter for often alcoholics or people in drug addiction. You used to sleep at night in these shelters. They don't have a doctor because they don't have an address, so they can't register properly. So they were outside the normal health service. I used to carry them into casualty for treatment because very often they would have real difficulty accessing any sort of care. As you've seen, we're moving away from single doctors practicing in their own practice, which in inner cities in England was normal, to have single doctors by themselves with 2,500 to 3,000 patients on their list, often again in poor areas, often in areas with low levels of literacy and education, often first generation immigrants, and they provided relatively poor care, because medicine, like all other disciplines, is changing fast. So we see quite a number of those doctors before the medical courts because they were becoming de-skilled, less skilled. So there is a move to multiple doctor practices on big modern health centres, often with other disciplines like social workers, dentists, chiropodists, physiotherapists, district nurses, all in the same centre, all doing what they do best, but working together as what's called a primary care team. So that the general practitioner now in a good centre will have access to lots of different expertise, and also will be on good terms with his local hospital, so will know which specialists are best for which conditions of his patients. We are trying to move to a system where the patient leads and has choice, but the reality in most areas is there isn't that much choice, although now for certain types of heart condition we might send the person down to London, we might send the person over into Europe. And I was told yesterday Prague sees a lot of people coming for specialist care from England because the costs are much lower. I can't say about South Korea, I don't know. And certainly my sister in Italy goes to France for her health care. So there is more mobility. But again, it tends to be mobility of those who are better off. So I think I said earlier, what for me was I had 7 years as a medical student without any charge. In fact, I got some state help because my parents were below income level. That's not true now. Now we have tuition charges going up to 9,000 a year. It's expected medical students will have large debts when they finish at university. So I presume more will want to do private practice to help pay back those debts. If you look at private practice, then orthopaedic surgery, plastic surgery, some types of medicine, especially obesity or heart medicine, have quite large private practices, but geriatrics less so. So what would I say to a Korean medical student? Come and spend a month or two shadowing on our clinical course. Encourage our people to come across to Korea, because in the end medicine is an international subject, isn't it? And you never know when your skills are going to be needed. I've done a resuscitation on a Spanish poolside, but clearly one has to be careful with one's qualifications, and we now, for getting into this country to practice, where you have very severe barriers and you have to pass an English test as well as a clinical test, and increasingly employers are being careful, because we get a number of overseas doctors who come here to do locums and run into bad problems because culturally there are big differences between the way medicine's practiced in different countries. I stop there.